Assalamu alaikum. A very warm welcome to all of you from Incepta. Today we are going to have a brief discussion about a groundbreaking product, Byjuard, which is a preparation of vonoprazan. Vonoprazan is a new class of drug known as potassium competitive acid blocker, also known as PCAB, that successfully overcomes all limitations of PPI and offers a far superior treatment option of GERD and hyperacidity disorder. In this presentation, we will be highlighting on gastroesophageal reflux disease, commonly known as GERD, hyperacidity, current treatment option for GERD and hyperacidity, limitations of these current treatment options, and how vonoprazan can overcome these limitations, and details about our Byjuard. Now let's have an overview on GERD and hyperacidity disorders. GERD is a reflux disease where the contents of the stomach flow back to esophagus and causes GERD symptoms. Hyperacidity disorders such as peptic ulcer disease and NSAID-induced ulcer, etc. are caused by excessive acid output of the stomach. To treat GERD and hyperacidity, PPIs are widely prescribed, among which esomeprazole is the most common one. But PPIs have several limitations due to their pharmacokinetic and physicochemical property. Today, we will focus on 6 major limitations of PPIs, and we will also have a brief discussion about a far better alternative of PPI that does not have any of those limitations. Now let's have a look on 6 major limitations of PPIs. Number 1 limitation of PPI is all the PPIs are prodrug. Therefore, a PPI is converted to active form sulfanic acid or sulfonamide. Then it binds to active proton pump to inhibit acid secretion. A highly acidic environment is required for activation of PPI, which is only available in canaliculi of parietal cells. If a PPI is not properly activated, treatment failure results in. Moving on to our next point. Our next point is all PPIs are acid labile. As we already know that all PPIs are acid labile and can easily be destroyed by stomach acid. Therefore, all PPIs are formulated as enteric-coated tablet or capsule containing enteric-coated pellet. That requires a lot of formulation and manufacturing challenges. Desired efficacy can be expected only from high-quality enteric-coated PPIs, which is quite tough to ensure. Number 3 point is lack of flexibility of drug administration. The activation of a PPI requires food-stimulated acid in the canaliculi of the parietal cells. The best efficacy from a PPI is achieved when maximum accumulation of the drug and low pH environment at the canaliculi coincides. But this ideal condition does not always exist. Let's have some different scenario of PPI activation based on dosage administration regarding mealtime. Let's start with scenario 1. In fasting condition, if we take a PPI, the drug is not activated properly due to high pH in canaliculi. As a result, treatment failure occurs. In scenario 2, if a PPI is taken long hours before having a meal, maximum drug accumulation occurs long before maximum acid output. When maximum acid output reached, drug concentration is low. That causes lack of activation of PPI and poor efficacy. Moving to scenario 3. When a PPI is taken with food, food decreases and delays the absorption of PPI. As a result, Maximum acid output and drug accumulation in the canaliculi does not coincide, which results in poor efficacy. Here is the scenario 4. If a PPI is taken 30 to 60 minutes before a meal, maximum acid production and maximum drug accumulation in the canaliculi occurs simultaneously. And this is the ideal condition. In this condition, maximum activation of PPI leads to maximum efficacy. But this ideal condition does not always exist. As a result, desired efficacy is not always obtained. Slow onset of action is another major limitation of PPIs. PPI has slow onset of action and therefore maximum inhibition of acid secretion is not obtained from the first dose. From the graph, it is clear that extent of acid secretion inhibition gradually increases day by day and reaches at peak. Maximum effect is achieved within 3 to 5 days of treatment with PPI. Another major limitation of PPI is its act only on active proton pump. A PPI cannot inhibit inactive proton pumps that exist in the cytoplasm of parietal cells. Following treatment with a PPI, inactive proton pumps are gradually activated and resumed acid secretion. Due to shorter half-life of PPIs, which varies from 0.5 to 2 hours, availability of the drug in the canaliculi decreases significantly. As a result, PPI cannot inhibit the newly activated proton pump and causes recurrence of symptoms. Higher inter-individual variation is another major limitation of PPI. All the PPIs are extensively metabolized by cytochrome P2C19 enzyme in the liver. There are 3 phenotypes of this enzyme. These are rapid metabolizer, intermediate metabolizer, and poor metabolizer. Due to presence of these different phenotypes, some patients experience rapid, some may experience intermediate, and other people experience poor metabolism of PPI. Patients experience different therapeutic response depending on these 3 different conditions. This is a considerable limitation of PPI. Due to the 6 limitations of PPI, significant treatment failure is observed in erosive esophagitis, non-erosive esophagitis, and nighttime heartburn. In clinical studies, 20 to 40% treatment failures in erosive esophagitis, up to 40% treatment failure in non-erosive esophagitis, and 38% treatment failure in nighttime heartburn have been observed with PPI. All these limitations of PPI compelled us to look for a superior alternative for GERD and hyperacidity management. Incepta introduces Bigerd 10 and Bigerd 20, which is the preparation of vonoprazan 10 mg tablet and 20 mg tablet. To ensure desired quality and efficacy, Bigerd is manufactured using DMF-grade API. Vonoprazan was first marketed in Japan on February 2015 for the treatment of acid-related disorders and adjunct in Helicobacter pylori eradication. Later in May 2022, vonoprazan got US FDA approval. Let's have a look on mechanism of action of vonoprazan. Vonoprazan is a potassium competitive acid blocker, also known as PCAB, which competitively binds to potassium binding site of hydrogen ion potassium ion ATPase, inhibits potassium and proton exchange, and thereby interfere in the final step of acid secretion. Here comes the most exciting part of the presentation. We will get a clear vision that why Byjudd is superior to all PPIs. Byjudd is free of all 6 limitations of PPIs that we have discussed earlier. It makes Byjudd superior to all PPI. Point number 1. Vonoprazan is an active drug. Therefore, unlike PPIs, vonoprazan does not require complex and multifactor dependent activation process before inhibiting acid secretion. It is readily absorbed and ensures fast, potent and sustained inhibition of acid secretion. Moving to our next point. Vonoprazan is stable in gastric acid and there is no risk of damage of the drug by acid in the stomach. Therefore, it does not require enteric coating like a PPI. Here comes another important point, that is administration flexibility irrespective of mealtime. Vonoprazan does not require food stimulated activation like a PPI. It can be taken anytime irrespective of a meal. Food has